I'm going to start and talk just a little bit about the parallel growth between us and NINR, and we thought it might be interesting for you to hear just a little bit about what it was like 25 years ago. First of all, in 1986, Doris Merritt was the acting director, and you notice that this says NCNR. This was the National Center for Nursing Research. We were not an institute at that particular point in time. And in 1986, a little bit later, Ada Sue Hinshaw became the director of NINR. And you can see what the budget was at that time, $16.2 million. And now in 1995, Patricia Grady became the director of the current NINR, and you can see how much the budget has grown. And this is attributed primarily, I believe, to our directors going in there and really pushing and promoting nursing research, and we owe them a debt of gratitude for how they've been able to increase this budget. So for 2010, we're up to $156 million. So that's a phenomenal growth. We don't know what the next budget is going to be, and we hope it doesn't go down any, but at least we're up to this level. Now, the priorities for nursing research back in 1986, there were three basic branches. There was health promotion and disease prevention, and the task was to promote general health, enhance the ability of persons to respond to actual or potential health problems. There was also a branch that was labeled acute and chronic illness that looked at technology, rehabilitation therapies, and epidemiological factors. And the third branch was research development and review, and I quote, to ensure adequate care of well-trained nurse investigators. So you can begin to see, and I'm not sure if care was the right word, but I've got a quote here, so perhaps it is. But you can see we really have not changed that much. We have some of the same basic priorities here that we continue to have today. The 2011 NINR research priorities, we still have indeed promoting health and preventing disease, improving quality of life, which was embedded in the 1986 one, eliminating health disparities, which is a little bit new twist now that we did not have as a main focus in 1986, setting directions for end-of-life research. And then we have specific strategies now for building science, integrating biological and behavioral science for better health, adopting, adapting, and generating new technologies for better health care, and that again continues that same thrust where we had technologies in 1986, and improving methods for future scientific discoveries, developing scientists for today and tomorrow. In 2011, there is a changing face, we think, of research, not only in nursing research, but in research across the board. But we have changed primarily in nursing from a single researcher focus to interdisciplinary, interprofessional teams now. So early on, we really focused on an individual investigator with perhaps a nursing team to conduct research. And now we're looking much more broadly than that because we can impact health so much better if we look across disciplines and put teams together that have a different foci. We also look at comparative effectiveness interventions that improve quality of life and care, etc. And comparative effectiveness is very important, especially as we begin to look at some of the cost savings that we need to institute in health care. Also, increased importance in translating research findings to improving health. We've all heard about the translational research centers and the impetus for trying to get our research results to the bedside much quicker than we have in the past. Typically, it takes about 10 years to get a research finding to actually impact clinical practice. We don't have that luxury any longer. We have got to impact health care much quicker and get our findings into practice much sooner because we have many people with different diseases approaching end of life that have quality of care needs, have health disparity needs, etc., that need our research findings now, not 10 or 15 years from now. And also, we are involving communities in research directions. We're doing some comparative effectiveness research and trying to get some community-based participatory research. This is a very good way to eliminate disparities and actually conduct research that's very meaningful to communities that can impact their lives immediately. Our research in the SNRS region has really grown. Prior to 1986, and remember we had NCNR at that time, there were very few nurses funded as principal investigators. Most nurses were part of a team, but were maybe a co-investigator, but were not a PI. The development of NCNR really resulted in expanded opportunities for nurses. Nursing research became much more valued. Nurses began to be appointed to different federal boards and really began to come into its own at that time. And the explosion of nursing research in the South after the formation of SNRS, this really paralleled what was going on at NCNR and NINR, and SNRS really has benefited from that also. In 1986, NCNR funded 45 research projects from the southern region. In 2010, this is phenomenal, NINR has funded 141 research projects from the southern region. And I think everybody deserves a round of applause for that. Also, we thought we'd do some historical firsts for you. The first president was D. Gene Wood, who we talked to just a few minutes ago. And as you know, the first conference was in Atlanta in 1987. In 1990, we had the first D. Gene Wood Scholarship Award, which went to Dr. Eileen Morrison. 1983, the first ANF Scholar, and I was fortunate enough to be awarded that. In 1996, the first Distinguished Researcher Award, which appropriately went to D. Gene Wood. In 1996, the Research in Minority Health Award, which went to Dr. Hattie Bessett. 2001, Leadership in Research. This was Dr. Barbara Holtzclaw. 2001, Hartford Jarrow Research Award went to Dr. Barbara Rodanis, who I might add was a fellow classmate of mine at Texas. And in 2010, SNR, and I believe this is the correct year, SNRS became the largest regional research society, and that shows phenomenal growth. We also looked at research-focused doctoral programs. How has this evolved in the South from 1986 to 2011? You can see in 1986 we had 38 doctoral programs, 11 of them in SNRS, in 7 states. In 2011, we now have 120 doctoral programs, 43 in the SNRS region, and we have some in every member state.